look at this problem from a big picture perspective. And I'm really just asking a basic question about this, which is why are drug mortality rates higher in some places than others? So today I have three main objectives. And the first is to dispel the myth that, at least when we're looking at this problem on average at a national level, that it's a disproportionately rural epidemic, and instead leave you with an understanding of the tremendous diversity across rural areas. As many of you who live in rural areas know, rural is not monolithic. If you've seen one rural community, you've seen one rural community. And while some places in the rural U.S. have among the highest rates of opioid mortality and other drug mortality, other rural places have among the very lowest rates in the whole country. Now, to be sure, rural areas face some unique and more difficult challenges with this problem due to factors like lack of treatment resources, smaller health and criminal justice workforces, more employer difficulty finding qualified workers, lower supply of ambulance. So I've talked with EMTs who say we have one ambulance and our ambulance is chasing one person around, kind of Narcanning them multiple times in a night. That's certainly a challenge that's more problematic for rural areas. And then, of course, greater stigma. The second objective is to try to refocus our attention from the individual level aspects of this problem to the more place-based or contextual nature of the opioid epidemic and really of deaths of despair more broadly. And I do this because I think a focus on the individual really masks what's going on at the population level. And you can see that in most of the intervention strategies and policies, insofar as they've really been focused on the individual, and therefore they're very downstream approaches to fixing this problem. So these include things like increasing access to substance abuse treatment, increasing access to Narcan, and certainly those things are important. But my position is that if we continue to go down that road without addressing the underlying economic and social drivers of despair and hopelessness and pain and isolation, not only are we not going to stop the opioid epidemic, but we're going to remain vulnerable to future drug and other health epidemics. And then my third objective is to caution us against an overfocus and an obsession with the opioid problem at the risk of ignoring related behavioral health problems that have similar underlying drivers. And this certainly includes other drugs. It also includes alcohol and suicide. So this map that you see here shows drug mortality rates at the county level from the early 2000s. The red counties have the highest rates and the blue counties have the lowest. And what you see here in the early 2000s is some clustering in central Appalachia, handfuls of counties with high rates throughout the Southwest and the Mountain West. But generally, what you see is that most counties had drug mortality rates lower than 5 deaths per 100,000 during the early 2000s. By the late 2000s, you can see many more counties are being affected, especially throughout greater Appalachia, Florida, the industrial Midwest, Oklahoma, and then large swaths of the Southwest and the Mountain West. Most recently, the clusters have grown quite substantially as mortality rates have continued to increase in these regions. Yet you'll also notice that parts of the Great Plains and Texas and the southern Black Belt Delta region remain relatively better off. And just to give you a flavor of the counties with the highest mortality rates in the early 2000s, Sioux County, North Dakota had the highest drug mortality rate in the country in the early 2000s. And both Sioux County and Buffalo County in South Dakota have large American Indian populations. And along with a couple of other counties in this top 5, Rio Arriba and Castillo County, Colorado, they're rural. But Baltimore County, with the second highest rate, is very urban. Now, something that these 5 counties and others that are ranked near the top do have in common is very high poverty rates. Just to give you a sense, in 2000, the average county poverty rate in the whole U.S. was 14.1, but the average among these 5 counties was 33.2, so over twice the national average. So this really starts to give us a clue about some of what may be behind the geographic variation that we see. By the late 2000s, what you end up seeing is some Appalachian counties are emerging in the top 5. You still have a mix of rural and urban. And then most recently, you see that the counties with the highest rates have rates that are much higher than those from the previous 2 periods. And with the exception of Cable County, the other 4 are rural. But again, one of the things these counties have in common is above average poverty rates. So you look at this map, and these counties with the highest rates, you see a lot of rural, but one of the things we tend not to notice is the counties with the very lowest rates are also rural. So one of the fascinating things about this epidemic is that there's much more heterogeneity, variation between rural counties than between urban counties. And maybe there are lessons we can learn from the rural counties that have the lowest rates. Maybe there are things that are going on right in those communities that we can borrow from. But as I mentioned at the forefront, I really think that our problem is bigger than opioids, and it's actually bigger than drugs. So what this chart is showing you are the number of deaths from drug overdoses, suicide by 3 different causes, and alcohol. And these alcohol deaths are primarily cirrhosis of the liver and alcoholic liver disease. Drug deaths have certainly increased the most, but deaths from each of these causes have increased, and we shouldn't lose sight of those. Suicides by drug overdoses contribute a relatively small share of all suicides. Most overdoses are due to firearms, and those have increased 38% since 1999. Other suicides have increased 80%, and deaths due to alcohol have increased nearly 80%. Now, these are just deaths where drugs, alcohol, or suicide were listed as the underlying cause, and that means they were the direct cause of death. And these don't account for deaths where drugs or alcohol factored into the death in some way. So, for instance, motor vehicle accidents or a heart attack that may have involved drugs or alcohol. When we count deaths with drugs or alcohol as contributing causes, we add about 35,000 more just in 2016 alone. And so when we count up all of these deaths, we end up with nearly 175,000 in 2016 and over 2.1 million throughout this period. Now, these are not cancer or some biological age-related death. These are all preventable deaths. So over 2.1 million preventable deaths since 1999 from drugs, alcohol, and suicide. Really quite a staggering number. Earlier in the map, we saw that many of the counties with the very highest drug mortality rates are rural. However, on average, non-metropolitan counties, and that includes both micropolitan counties and non-core counties, these are all considered to be non-metropolitan, they don't actually have higher drug mortality rates than metropolitan counties. In fact, large fringe metro counties, kind of the exurbs from the large central metro areas, and medium and small metro counties and micropolitan counties are all fairly comparable. What we can see here is that these large central metro counties, the largest counties in the country, places like New York and Baltimore and LA, places like that started with the highest rates, and they far surpass other types of counties in the early 2000s, but increases in those really urban places have been less significant than in small metro areas and non-metro areas. Now, one of the things that's important, I think, is that the emergence of fentanyl in recent years has really hit metro counties, the largest metro counties, hard, and we should expect to see upward trajectories in those largest urban areas over the next couple of years as a result of the surge in fentanyl. I think much of the confusion about whether the drug problem is disproportionately rural or whether there really aren't rural-urban differences has to do with the tremendous variation across different rural areas. So as I mentioned, some rural places have been hit really hard while others haven't seen much effect at all. So this chart shows average mortality rates for non-metropolitan counties only. In each of the USDA's categories of economic dependency, and those categories are based on employment and income into the county from different industries. And there are really 3 major takeaways here, I think. The first is that in all 3 time periods, mining-dependent counties had the highest drug mortality rate, and farming-dependent counties had the lowest. The second is in all types of counties, the average increased across all 3 periods, but the gap between mining dependent and the other county types got much larger. So, mining dependent counties were hit especially hard, and the gap between them and everybody else really extended. The third takeaway here is that the ordering, the hierarchy stayed the same across these different county types. So it's always been the case that mining have been the highest, recreation next, non-specialized next, and so on. And that kind of gives us clues maybe about the conditions from a couple of decades ago and how those conditions may be affecting drug mortality rates now. In the maps you saw earlier, you probably noticed a lot of regional variation in drug mortality rates. So for instance, Appalachia, the Southwest, parts of the industrial Midwest, those places showed up as disproportionately affected. But even within these regions, we see a lot of variation. So these charts show drug mortality rates only for the non-metro counties in each state. So for example, if you can see the top left, the collective mortality rate for all of the non-metro counties in New York in 2016 was 19.8. In the Northeast, non-metro New York remains better off than non-metro Pennsylvania, Massachusetts, New Hampshire, or Connecticut. In the Midwest, non-metro counties in Ohio have a much higher collective rate than the Plains states. And with the exception of Ohio and Indiana, the rural Midwest has lower rates than the rural Northeast. There's also wide variation in the South, with non-metro counties in West Virginia and Kentucky really exceeding everywhere else, whereas Texas, Mississippi, Georgia, they have rates that are more in line with those Great Plains states. And then collectively, the West has higher rates than the Midwest and the South, but non-metro counties in California are the big outlier here, and I think that, that sometimes surprises us. Many of us might be surprised that California collectively has the second highest non-metropolitan drug mortality rate in the whole country, right after West Virginia. So what I hope you're getting from these slides so far is a sense of the wide variation in this problem, wide geographic variation. And in some ways that makes it difficult to understand why rates are high in some places and low in others when there aren't nice regional patterns for us to try to disentangle. So I'm going to come back to what these places have in common in a minute. But before I go there, I just want to give you a sense of which drugs are contributing to all these deaths. So these two charts show the percentage of all drug-related deaths that involve specific drugs separately for metro and non-metro areas. And the takeaways here are, first, in metro areas, heroin and synthetic opioids have been bigger problems than prescription opioids in the last couple of years. The second is that prescription opioids, these are the opioid analgesic line, the solid red line. Prescription opioids have consistently been, and they remain, a bigger problem in non-metro areas than do heroin and synthetic opioids. Synthetic opioids are fentanyl. But the share of deaths involving prescription opioids has been declining in both metro and non-metro areas in the last few years. The third takeaway is that the contribution of benzodiazepines, that's the green line, and psychostimulants, that's the teal line, and those include methamphetamine. The contribution of those have increased in recent years and are expected to continue to increase. The fourth is that the contribution of cocaine to drug overdose deaths declined through the 2000s, but it's showing signs of reversal in recent years. And in fact, NPR just did a story this morning about the increase in cocaine that's laced with fentanyl. And sometimes that's intentional insofar as dealers want to get clients hooked on opioids, but sometimes it's unintentional and just a result of kind of messy packaging where the cocaine gets contaminated. One of the interesting things is that the common narrative about opioid addiction has been that most heroin users started by first getting hooked on prescription opioids. And although that may have been the case several years ago, research is increasingly showing that more people aren't starting with prescription opioids at all, that other drugs are often serving as the gateway to heroin, and cocaine is one of those. So some colleagues and myself are conducting a study in rural Pennsylvania where we're interviewing and collecting some network data on opioid users in this area and asking them kind of about their trajectory into heroin. And many of them have told us that it wasn't that they started with prescription opioids first, it was that the dealer, they were using cocaine or some other drug, and the dealer said, hey, why don't you try this? And then, maybe they gave them the first one for free, or maybe they just didn't have cocaine that day, and so they tried the heroin, and that was their entry into heroin. not the prescription painkillers. So the takeaway from that is that there are many different types of transitions into heroin, and that narrative of prescription painkillers to heroin is true for some groups of people, but it's not true increasingly for other groups. And then the final thing to take note of here is that there's a lot of drug mixing going on in overdose deaths. So over half of overdose deaths involve more than one drug. So as a result, I think we really can't put all of our eggs in the opioid basket. We have to take into account how all of these different drugs are being used and working together. So how do we get here? For me, how to tackle this problem depends on exactly which problem we're trying to solve. Or are we simply trying to save lives right now, or are we interested in dealing with the underlying causes that got us here in the first place? So to think about that, I've been using this analogy of the spark versus kindling. And by now, many of us are well versed in the spark part of the story. You know, pain is the fifth vital sign. Drug companies, big pharma misleading physicians, the heavy marketing of Oxycontin, the pill mills. People who I meet on a regular basis can now narrate this story to me. So this is the story that has emerged, and people have heard a lot about it. And certainly widespread drug availability, especially the widespread emergence of powerful and incredibly addictive opioids, was really the spark that started this fire. But in order for a fire to catch, you need kindling. And drugs, alcohol, suicide deaths are not a random collection. They often derive from depression, hopelessness, chronic pain. And at the foundation of all of this, the kindling, is long-term economic and social decline that is captured in disconnection and isolation. So when we start looking at the factors that explain most of the geographic variation in drug mortality rates, in other words, this question of why are rates so much higher in some places than others, we find that the factors that explain this variation really fall into three baskets: economics, family, and community. And of course, these three arenas don't operate independently. They overlap and they compound each other. So what do these factors have in common? Well, the tie that binds work, family, and community distress and decline is isolation and disconnection. So when you think about it, work, family, community, these are the three arenas to which we attach meaning in our lives. But for many people and places, these institutions have unraveled, and they've left people with little meaning in their lives, little reason to get out of bed in the morning. Opioids are the perfect symbol of isolation. And in some ways, we've destroyed all of the things as a society that brings us together. So let me give you some examples of what this looks like using mortality data. So what this chart shows is the increase in the drug mortality rate for a standard deviation change in the predictor variable. So for instance, for every standard deviation increase in the percent separated or divorced in a county, we see about 26 more deaths per 100,000 in that type of county. So all the red bars are showing you factors that are associated with higher drug mortality rates in a county. And what you notice these things have in common is that they have to do with family, they have to do with work and the economy. So things like declines in median household income, manufacturing job loss, unemployment, poverty, or they have to do with the family, as I mentioned, percent divorce separated single parent families. These are the types of things that increase drug overdose rates in counties. Conversely, the blue bars are showing factors that buffer against higher drug mortality rates. So, for instance, a standard deviation increase in the number of religious establishments per capita in a county is associated with about 15 fewer drug overdose rates per 100,000 population in a county. So these community membership associations, opportunities for people to get together and to interact, those are buffers against higher drug mortality rates. So let's think about the economic part of this for just a minute. The Pew Research Center regularly conducts these surveys about optimism, allowing for comparisons over time. And in this survey, they ask people ages 25 to 54 to rank their standard of living compared to their parents. And what they find is that whites without a college degree are far less likely than blacks or Hispanics to indicate that their standard of living is much better or somewhat better than their parents. And in addition to that, the perception of doing better than their parents has drastically fallen off for whites since the 2000s. And of course, as many of you may know, drug overdose rates are much higher among whites than they are among blacks or Hispanics. And they're much higher, especially among those without a four-year college degree. So I think we need to think about reference groups. When we think about how we're doing in life, we often compare ourselves to our parents, right? So this means that many non-college educated whites are comparing themselves to a generation that had more opportunities than they have, a generation where those without a college degree could get decent paying jobs, even if those jobs were dangerous and very physically demanding, and of course many of them were. Blacks and Hispanics, on the other hand, are comparing themselves to a generation that had fewer opportunities. So even though objectively blacks and Hispanics are doing much worse than whites still, they're comparing themselves to a generation that had it even worse. So this means that whites are likely to compare themselves to a reference group that may lead them to feel worse off, whereas blacks and Hispanics might be comparing themselves to a reference group that may make them feel as if some progress has been made. There's been some really excellent research done by Carol Graham at the Brookings Institution that shows us that people who are hopeful and optimistic about the future are more likely to invest in that future, and they have better health outcomes. Whereas people who are consumed with stress they end up being less confident that investments will pay off, and they sometimes engage in self-harming behavior. Many of you may by now have heard of and read this fabulous book, Dreamland by Sam Quinones. And in this book, Sam really shows that the opioid problem and other problems like alcohol and mental health problems didn't just emerge in small town and rural America overnight. He explains and demonstrates how it wasn't new. It had been happening for 15 years already, and we weren't paying attention to it, and it was about more than drugs. And ultimately, it signals for me that the U.S. despair problem is driven by a really complex interplay of factors that have undermined the very institutions to which we attach the most meaning in our lives: work, family, and community. And importantly, there's nothing new here. This has been building for 3 or 4 decades, at least since the 80s. And really, the hens have come home to roost, so to speak. Getting to this idea of isolation and disconnection and the role it's playing, opioids really are a symbol of isolation. People often use them alone. Isolation and disconnection can explain, too, why even people who are not poor and even people who don't live in poor communities sometimes turn to drugs and overdose. So it's not all about the economics. It's really about this underlying issue of isolation and disconnection. And when we think about it, we're really simultaneously the most connected and disconnected society there's ever been. More people are living alone today than at any point in the country's history. And humans weren't designed to be solitary creatures. Loneliness, as it's measured in surveys, has doubled since the 1980s. So in 2 recent surveys, 40% of adults said that they were lonely, and that's up from 20% in the 1980s. Loneliness isn't designed to be chronic and long-term. It's very much like physical pain or hunger, and it's increased along with frenetic lifestyles, our lifestyle of overconsumption, where we've really traded friends and relationships for things. It's interesting, as house sizes, square footage of houses have increased, people's number of friends in their network has decreased. So when you think about social media too, it brings us together and it drives us apart. A lot of people quantify their social standing by how many friends they have. In both humans and in other social mammals, social contact reduces pain. That's why we hug our children when they hurt themselves. Affection is a really powerful painkiller. Opioids have taken the place of that. So opioids relieve both physical agony and distress of separation. You think about the animal world, which groups survive, and among social mammals, survival is greatly enhanced when they are strongly bonded to the rest of the pack. And it's the isolated and the marginalized animals that are the most likely to be picked off by predators or to starve to death. So it's not surprising that social isolation is strongly associated with depression, suicide, anxiety, insomnia, fear, perception of threat, overeating, and of course other harmful coping behaviors like drug and alcohol misuse. Now, even if you don't personally know someone who is struggling with addiction or don't have a family member or a friend who has dealt with this, the drug epidemic has important long-term implications for community sustainability. So we all really have to care because we're all kind of in the same basket here in terms of the cost to society. For example, the labor force nationally, around 23% of men who are working age, 25 to 54, nearly 23% of them are not working. But in Scioto County, which is a particularly hard-hit part of southern Ohio, it's 42% of males in that working age group who are unemployed or out of the labor market. That's a massive chunk of working age men who aren't working. Employers are having a hard time finding workers who can pass drug tests. There have been major increases in children who are living in foster care, living with their grandparents. And white deaths now exceed births in a third of U.S. states. First responders are overwhelmed with overdose calls. So this is a problem that affects us all. So where do we go? As I mentioned earlier, I pushed the question, are we trying to save lives right now and get a tourniquet on the problem? Or are we interested in investing the time and resources necessary to address the underlying conditions that got us here? And I like for people to read this passage from a book by a medical sociologist, John McKinley, who's written about the political economy of illness. And he writes, "There I am standing by the shore of a swiftly flowing river, and I hear the cry of a drowning man. So I jump into the river, put my arms around him, pull him to shore, and apply artificial respiration. Just when he begins to breathe, there is another cry for help. So I jump into the river, reach him, pull him to shore, apply artificial respiration, and then just as he begins to breathe, another cry for help. So back in the river again, reaching, pulling, applying, breathing, and then another yell. Again and again, without end, goes the sequence. You know, I'm so busy jumping in, pulling them to shore, applying artificial respiration that I have no time to see who is upstream pushing them all in." And so I equate this to the opioid epidemic in a lot of ways. When the easy, quick fix solutions are things like increasing access to Narcan and increasing access to medication-assisted treatment, certainly truly important. But in our daily work and our work with people who are dealing with addiction and our reporting on the problem and our policy making, we can't ignore what's going on upstream. Focusing on the individual is important, and those downstream approaches will save lives, but we're simply not going to Narcan our way out of this. The solutions to this problem are not quick and easy. We didn't get here overnight. It took us decades to get into this problem. And what got us into this problem to begin with was an easy answer to very complicated problems, like chronic pain and disconnection. All of our heroin and most of our fentanyl is already coming through walls, so adding yet another wall is not going to stop the supply, and it certainly won't fix demand. I have listened to Sam Quinones talk about this, and he talks about the need for models, big picture models, like the Marshall Plan. So the Marshall Plan was an American initiative to aid Western Europe, where the U.S. gave over $13 billion, which is about $110 billion in current dollars, in economic assistance to help rebuild Western Europe and the economies there after the end of World War II. We really need to start thinking about the economic and social decline that has befallen many parts of the U.S. over the last 30 years as being akin to the devastation from war. Even though it's not war, the destruction in a lot of these communities looks a lot like that post-war. But this can't be about government doing it all either. It has to be about collaboration and community cohesion. And one of the things that we're seeing out of this epidemic is that small communities are really bringing together groups of people from different organizations and backgrounds to tackle this problem. And this is kind of happening organically. Opioids are just so connected to isolation. They thrive on isolation, and the only way to combat this problem is community. So as Sam Quinones says in Dreamland and in his talks, the antidote to heroin is not Narcan. The antidote to heroin is community. And I really do think that's true, seeing what's emerging now with folks trying to come together and talk about and implement strategies to address this problem. So I'll go ahead and stop there. And I'll be happy to take some questions as they come in, if I can get to that screen.
Thank you, Shannon. Are you able to see the chat discussion?
I can see the chat now. Yep.
Well, for the audience, if you have a question, now is a good time. There is a link from Timothy about psychedelics or LSD as being an alternative to heroin. I don't know if you have a thought or comment on that.
Oh no, I'll have to check that out and read that. I haven't looked into that literature at all. It certainly sounds plausible. I know that LSDs, ecstasy, for instance, are often used among military veterans who are suffering from PTSD, and there's been some evidence to suggest that it's a positive treatment for PTSD. Medical marijuana has also been found to be an alternative to chronic pain treatment that, while it could also be addictive, certainly contributes to fewer deaths.
Yeah. I see Joel has a question here.
What are the evidence-based solutions to deficient community interaction? That's a great question, and I'm not sure that there are evidence-based. I think this looks different in different communities. One of the things that you can look for is when you're driving through a neighborhood, do you see people walking out on the streets, or is everybody kind of locked away in their homes? Are there places where people have opportunities for interaction? And this doesn't necessarily mean like community centers, right? This could mean faith-based organizations. It can mean community membership associations like the Elks Club or the Lions Club. Is there apparatus in place for people to actually come out and chat with each other? Because those types of things have been shown over and over again to increase community trust and social cohesion. I'm just waiting for some other questions. Why are the numbers in West Virginia and California so high? So I think it goes back to what these places have in common. And when we start breaking down the characteristics that are kind of driving this spatial variation between high mortality and low mortality counties, it has to do with those factors that I talked about in that slide with the bars. So economic decline and distress, family distress, higher rates of divorce separation, single parent families, higher poverty rates, unemployment rates, lack of these community institutions that bring people together. And so in Northern California, where the rates are high, in West Virginia, these are places that have kind of been devastated over the past 20 or 30 years from losses in mining in the case of West Virginia, and then some extractive industries in the case of Northern California. It seems like funding is going to more downstream measure interventions like Narcan. Do you see increased funding for these upstream measures in terms of education and prevention programs? Certainly, as I mentioned toward the end, ideally we would have a massive plan like the Marshall Plan. I don't know that there's any political will for that right now. I think a lot of this is going to have to be at the community level, where local communities themselves decide that they want to put some funding into, kind of changing the way that we think about education in those places, or thinking about prevention among the young, or thinking about ways to bring community members together. I do think that there are a couple of things nationally that the government could do, and one of those is to try to invest in employment opportunities for folks without a four-year college degree, and for youth who are not interested in getting a four-year college degree. And community colleges and trade programs in rural areas, I think, are a mechanism for doing that. So working with more employers in these small communities to identify where the skills gaps are, and valuing those trade programs, those certificate programs, just as much as we do for kids who are going to college. I think one of the things that happens is in rural areas, kind of channel kids into, these are the kids who are academically inclined, and we're going to push them to go to college. And what ends up happening is you push kind of the most academically skilled kids out of the community, and it leaves behind these kids who weren't interested in or didn't have the resources to go to college. But that doesn't mean that they shouldn't have opportunities to get training and skills in some decent paying trades like welding or plumbing or electric or or IT infrastructure building. And so I think the federal government can kind of promote these trade programs as being just as worthy as college.
Gail has a question as well about getting local results for her county in Colorado.
So if you're interested in trying to find mortality rates for your own county, you can go to the Centers for Disease Control website. It's CDC Wonder. And when you get into CDC Wonder, you can identify several different parameters for the mortality rates that you want. Now, this is easier said than done in a lot of ways. And if your county has fewer than 10 deaths in any given time period where you're trying to kind of extract those results, then the data are suppressed. I have the restricted data that I'm using for my analysis, so I have the death certificates for all deaths in these counties, but I am not authorized to share that information because I had to go through a vetting process to get them. I see that
I see.
Many people are typing.
Yeah. So I'm thinking we can probably handle a couple more questions, and then we can direct people to you if they want to follow up with you with some of their other questions as well.
Yeah, I am. Okay, so Meredith shared the county health rankings link, and I mean that's one option for getting mortality rates. What you're going to find is that they're banded, they're in ranges, and for a lot of those, actually for all of them, they're not calculated directly from the mortality files themselves. They're kind of imputed based upon the economic characteristics of a county. So you'll get a range, but it's not necessarily the exact mortality rate from the county. Sarah asked, when we deal with community on how they want to solve problems, conversations invariably turn to things like access to clean water, community activities, and other things that are beyond our scope. As prevention, are there counties that are successfully integrating programs and funding to tackle the larger problem? I don't have the answer to those questions. One of my goals is to try to do a systematic study on what some of the interventions have been and which ones have been successful, because I think you're right, communities are trying a lot of different things. They're throwing a lot of resources and different approaches at this problem, and there's not much evidence right now on what seems to be working the best. But I think, what I would do is try to look at some websites for prevention efforts in some states like West Virginia and Kentucky that have been dealing with this problem for a really long time, because I do think they might have some innovative programming going on, and I'm just not aware of the names of those programs.
Well, before we finalize or finish our webinar, I just want to encourage everybody to provide some feedback for us. So what I've done is I've posted a little questionnaire here. It'll just take you a minute or so to respond. We really appreciate your feedback. Shannon, thank you very much for giving us this great information. A lot of what there's a lot, I think that what you've shared resonates with all of us and our experiences, so thank you.
Thank you for having me, and my email was at the end of the slides, so if you have questions that weren't addressed, feel free to email me. It might take me a couple of days to reply because I see a lot of questions here, but certainly email me with any that you have, and I'll do my best to answer them, and if I can't, I'll try to direct you to other folks or resources that can.
All right, well that sounds really good. We'll leave things open here just for another moment or two for people to provide that feedback for us. Thank you everyone for taking time, and as I had mentioned in the beginning, we do have another webinar coming up on June 19th, 1 p.m. Eastern Time, with Dr. Michael Brumage at West Virginia University, and the title of that talk is Adverse Childhood Experiences, a Driver of the Opioid Epidemic, and I think that topic will dovetail very well with yours too, Shannon, so
Okay, great. Yeah, I mean, and I think, somebody mentioned a question about that. And that's one of the things that we aren't talking about a lot with this problem is that a good share of the people who get involved with substance abuse do have adverse childhood experiences and they're using substances to cope. And so it's something that we really have to deal with. It's another one of those really downstream drivers that we have to deal with if we're going to decrease this problem at all.
Right, right. Well, okay, I think now is a good place to end the session. Thanks again to everyone for joining us, and thank you, Shannon.
Thank you.
Have,
Take care, everybody.
talk with everyone soon.